Stay good.
The last point here is important, feeling confused, resistant, or defensive is very common because again, some of the information we're going to discuss is very different than what you have heard before. Weight stigma. What comes to mind when you guys hear weight stigma? So people pretty much, judge just based on their weight and being put in a position that is less optimal than other positions in life. There's quite a bit of interesting data about weight stigma and looking for jobs. You're nodding, yes. What do you know about that?
Just, I've done a lot of hiring and I've been a part of hiring teams. And when you look at qualifications on the resume, someone is clearly above other people. But then when they get rated, if they're in a larger body, oftentimes their rating is the lowest. And so I would have a probe and say, why did you score this person there? It really opened my eyes to the prejudice that does exist.
That's a
bias.
very insightful comment. And there actually is quite a bit of, true data that, judging people by their, and that's one of the reasons why, now we don't have pictures on, I come from a country in Europe, and when we used to submit resumes, you actually had to have your picture there. So I think that's really cool that we don't do this here because people really start judged by their qualifications first, and then by their looks. So weight stigma is the stigma related to the body weight, like literally the vehicle, the vessel that our souls reside in, the body, without looking into anything else. I have presented some data here about weight stigma in healthcare. Going to read through some of those slowly to kind of help your brains turn around the idea of weight stigma. So over 50% of primary care doctors see clients in larger bodies as awkward, unattractive, and non-compliant. So just think about that. Over half of the doctors out there, and that is their bias. They don't know anything about that patient. They see them as awkward and non-compliant. And over 1/3 are describing them as weak-willed, sloppy, and lazy. That is something that I hear from patients who have been seen by primary care doctors and were told, to just lose weight and you're going to be happy and well quite a bit. Unfortunately, this leads to something that I'll discuss a little bit later, is the fact that patients are not motivated to receive medical care because of this. If you go to the doctor and time and again, you hear you need to lose weight, you need to exercise more, and most of your problems are going to be resolved. By year 7, you just don't go, or you don't bring that up for discussion. Those with higher weights were rated as less adherent to medication by physicians. So again, without any other additional data about the compliance of this patient and reasons for the compliance, the fact that they're in a larger body implies for their physicians that they're not taking their medications as prescribed. In addition to physician reporting a strong preference for thin rather than larger body people, strong implicit anti-fat bias was found among a large group of physicians. So this is, flat out there. Doctors are saying that, if they have to choose between choosing a patient in a smaller body and a larger person, they will choose the one in a smaller body. Clinicians spend less time with and engage in less health education with patients with higher weights. This truly is very sad because that means that people who are in larger bodies actually are receiving a very different type of medical care compared to people who are, quote unquote, like normal weight. And I want to provide another anecdote here that's actually very recent from my practice. I treat a lady who's in a larger body. She had a knee trauma, went to her doctor, and pretty much for a year and a half, she was told that she needs to lose weight. Got to the point that her knee's so messed up that she actually used to have surgery. She was actually telling me that another friend of hers who got hurt around the same time, was in a smaller body, was immediately advised to go through a surgical procedure, and everything is fixed. And my patient was saying, and she runs marathons. She's really physically active. So she was saying, when I was actually sharing with my doctor that, I need to go back to my normal physical activity because I love it. She was like, you can just see that it just went over his head, it's like, yeah, sure. So a very true life example of how, two people who had pretty much the same issue are being treated differently just based on the way that they look. Seeing weight as an indicator of health has been shown to lead to greater weight stigma and different treatment recommendations. So this is pretty much that's a recent paper actually. They were talking about patients are getting less medications for migraine headaches, if they're in a larger body compared to someone who's in a smaller body. So all this kind of brings our attention to the fact that, the assumption that we started with can be actually very harmful in the context of how we are receiving medical care. Weight stigma leads to weight discrimination. Again, there are, those are just, a few studies. There's a whole lot more. We just picked for this presentation some that are kind of really striking. A few examples for example, those who are overweight and exposed to weight stigma consume greater calories than those who are not exposed to weight stigma and weight discrimination. So you see how the cycle, turns in the wrong direction. You stigmatize someone for being in a larger body, and that results in them actually doing behaviors that are increasing weight and decreasing their health by consuming more calories. Those who internalize weight stigma have lower level of exercise, very consistent again with the message above. Those who are experiencing weight discrimination turn to food to cope with being stigmatized and have higher levels of emotional and binge eating. So pretty much by, not talking to the person and assuming that they are something, which is the weight stigma, we are the ones that are more or less being discriminatory regarding their weights. And this unfortunately makes things worse by making them engage in behaviors that are unfortunately perpetuating that cycle for them. Perceived weight discrimination has been found to be associated with increases in weight and waist circumference over time, as well as the onset of obesity. So this is something, again, that is very, very common in medical practice, is when, the person, for example, shares concerns about binge eating with their physician. They're in most cases not listened to. They're told to just go and exercise and eat better. Again, very good example of weight stigma and weight discrimination, which leads to them going home and continuing with these behaviors just because they're not getting the adequate help that they need. What are the results of weight discrimination for patients and then general health outcomes? Patients avoid obtaining healthcare. That's something that I mentioned and that I have seen with my very eyes. People just give up and they try to switch physicians and then they finally are like, they feel disrespected by healthcare providers, so they lose trust in their doctors. They do not feel they'll be taken seriously due to their weight and report feeling all their health problems are blamed of weight. I hear this in my office probably 10 times a week. The people are really not asked the questions about the knee, for example, like, how did you hurt your knee and what can we do to fix it? But they're pretty much told that, because of your weight, there's really nothing else. Patients eventually are reluctant to express weight concerns with healthcare providers. There's a lot of shame and guilt associated with people who live in larger bodies. And unless we as healthcare providers manage to open the conversation in a way that supports patients in their struggles, within their concerns, there's really no way we can move this forward. The health outcomes related to weight discrimination are increased blood pressure, chronic inflammation, high cortisol and C-reactive protein levels, and increased likelihood of mood and anxiety disorders. So by now, you hopefully have a mental picture of how, a person in a larger body is not receiving the health they deserve. And then on one hand, on the other hand, this leads to perpetuating the cycle. This brings me to the philosophy of our group at the Lindner Center of Hope's kind of treatment program of how we feel weight should be conceptualized in medical care. So we follow the health at every size philosophy and concept. Health at every size supports people in adopting health habits for the sake of health and well-being rather than weight control. So you will see that the more we talk about health at every size, the less we talk about weight as a number on the scale. And I'll very briefly elaborate on why we do that, but pretty much the focus here is on health. The focus is not on weight. The focus is on health and well-being and what this means. Health at every size encourages eating in a flexible manner that values pleasure and honors internal cues of hunger, satiety, and appetite. So when you guys read through this, eating in a flexible manner that values pleasure and honors internal cues of hunger, satiety, and appetite, does that include eating Chick-fil-A? Yeah. Chick-fil-A brings great pleasure. And if you're hungry and you know this is what you're driving by, and if you feel like Chick-fil-A, of course. Would that eating in a flexible manner support eating red velvet cake? Yeah. As eating quinoa salad or eating green salad or anything you can think of. So pretty much this summarizes the idea that, you know, we want to be eating a variety of foods whenever we feel whatever we feel like, which is the premise behind intuitive eating. When the point here is pleasure, internal cues of hunger, satiety, and appetite, and not what's considered good or bad food. Second principle of health at every size, finding the joy in moving one's body and becoming more physically vital. What does that mean? So that's another way to say exercise, right? But without that word that I think everyone is so sick of hearing. We're talking about moving one's body and becoming more physically vital. So if a person is in a larger body, let's say they're in a body that really, it is very hard for this person to get on the floor and do yoga or run a marathon. If we suggest to this person to go exercise, this can be very intimidating. And that oftentimes leads to nothing because they don't know what to do. When we talk about joy in moving one's body and becoming more physically vital, this can literally be doing this 25 times a day because this is movement and it is making your blood flow and your muscles work. The third principle of health at every size is accepting and respecting the natural diversity of body sizes and shapes, which brings us to the initial point that, you know, bodies come on a very, very different spectrum, depending on many factors, by any means, not just nutrition and exercise levels. You know, we have different genetics, we come from very different ethnic backgrounds, so there's really no way that one size can fit all. And being respectful towards this makes us truly understand that the weight as a number on the scale is not a metric that is helpful in medicine. So principles of health at every size, weight inclusivity, accepting and respecting the diversity of body shapes and sizes, health enhancement, improving access to information and services, attending to physical, spiritual, social, economic, emotional, and other needs. So as you see here, you know, health by any means is not just physical health. We're talking about many other components. Respectful care. This is owning the biases, ending weight stigma and discrimination. Eating for well-being, promoting eating in a manner which balances individuals' nutritional needs, hunger, satiety, and pleasure, and then life-enhancing movement. So if you read through all this, in a nutshell, it again talks about, you know, the proverbial diet and exercise that we hear from our doctor's offices a lot. However, phrased in a very, very different way, which really supports the individual rather than putting them down because they're not exercising enough and they're not dieting and resulting in a particular weight. Eating for well-being is a very very important component that we don't stress enough. Even when kids are very little, we talk to them about good foods and bad foods and rather than actually teaching them how to eat intuitively and which they know, for I know the audience who have, I'm sure many people have raised children, and when they're very little, they know when to stop. I remember my son, that was driving me crazy. Like he would eat and would like literally stop at half of the bite and would put the fork away and be like, done. It's like, you have 2 bites, finish the meal. The more I know about this, the more I know how wrong I was, because this is true intuitive eating. This is intuitive eating at its best, like a 4-year-old who knows exactly when to stop. So we have those skills, we were born with them, and then we unlearn, unfortunately. Hopefully, the more data we have, the more we know about dieting being really harmful for the individual, the more we can tune back into that toddlerhood and remember what intuitive eating was all about. Now, going back to the idea of health and wellness, I touched upon this a little bit, but as you guys can see, we don't have weight there, right? Any of those circles, we really don't have weight that's part of being part of the picture of health. We have diet. Here we don't mean dieting, we mean actually eating diverse foods. Exercise, there's emotional component, emotional well-being, social, spiritual, intellectual, and then environmental and occupational. There are many aspects of many things go into the picture of health. However, what we get from the media, or we used to at least in the last 20 years, is that thin is healthy and fat is unhealthy. And I think you all agree that this is every magazine you open, or any social media you open, this is what you see. We are told that we need to eat better and then you'll be healthier, which really does not mean anything, because better is compared to something else. And in order to be better, you need to have some baseline. And you need someone today that this baseline is not good enough. And there's really no baseline that is not good enough as long as it provides good nutrition for the body. Exercise more and you will be healthier. Again, not really know what that means, but this is what we're told. So this is this constant limbo place that we're left at, always having the feeling that I'm not doing good enough job with the recommendations that I'm given. When we're not really told, what are we comparing to? What is really better? Health is about more than weight, and health is about more than just diet and exercise, as we're trying to portray there with this little graphic. What are your thoughts on the media exposure and what we hear from everywhere, really? TV, social media, magazines. Do you guys agree? Go ahead. No, oh no, Would the audience agree that the prevalent feeling out there is that thin is healthy and beautiful, and everything else is not? Okay. Unfortunately, yeah. Now, correlation really does not equal causation, and I do like this cartoon here. It says diabetes has increased dramatically over the past 20 years. That proves that diabetes is caused by global warming, because we know that global warming is also. The reason I have this here is that we are told that there are many obesity-related conditions, for example, heart disease, stroke, type 2 diabetes. When the prevalent notion from the health at every size movement is that probably the better word to use there actually is associated, because related implies that there is correlation. So if you are in a larger body, then you will have heart disease, or if you're a larger body, you will have stroke. And this really is not the case medically. The BMI that you're all very well aware of is the metric that is used in modern medicine to pretty much put us on that spectrum of health versus not healthy weight. BMI is weight and a metric that takes weight and height in consideration, and that is all. And then puts us, in those categories of underweight, normal weight, overweight. There are three classes of obesity. I'm sure you all have heard about BMIs from your doctors. You know what your BMI is. However, this is a really curious story of how BMI came to play, and really makes us wonder why are we still using it so much. So BMI was created by an astronomer in the 1830s to test the laws of probability. So this actually came to play to measure planets rather than human bodies. In 1899, insurance directors noticed a correlation in mortality rates, how it relates to overweight. And there is no really hardcore science behind BMI and in healthcare. Insurance companies lobbied the medical community to incorporate weight as an outcome of health. And then later in 1998, the NIH modified BMI criteria. And this is when, some of the audience remember this, when, suddenly a very large proportion of the nation became, obese and overweight overnight, and when the obesity epidemic started. The new BMI cutoff criteria are based on a report published in the International Obesity Task Force. And this task force is actually a group of people that is primarily two companies who manufacture weight loss drugs. So it's called Novo Roche and Abbott. That history provides some data on how BMI came to play, and it got picked up by the medical community because it is actually a very convenient metric, to be able to put people in right drawers of health. However, there's really no medical justification behind it. The issues with BMI, it is not meant to be used for individual use, right? I mean, it started as a metric to use for planets, and then suddenly we are using it, like imagine like cosmos, and now we're just like really putting it on one individual. It only considers height and weight, and it does not take into account pretty much anything: muscle mass, gender for adults, weight history, frame, or ethnic background. Because just if you close your eyes and try to imagine people from different continents, we are built differently. Does not account for ethnicity related differences. So this is the issue with BMI. And I'm not saying that, it should be deleted from the history of medicine by any means. I'm just saying that all of us need to be more critical when we think of BMI is that as that one metric that once we see it, we decide to know what category the patient should get into. Why BMI is not to blame. This is a citation from Mr. Bacon, who's one of the founders of Health at Every Size. While it is well established that obesity is associated with increased risk for many diseases, causation is less well established. So here we go to the global warming and diabetes, right? I mean, there might be association. We know there is association between obesity and certain illnesses, but this is not causation. Epidemiological studies rarely acknowledge factors like fitness, activity, nutrient intake, weight cycling, socioeconomic status when considering connection between weight and disease. Yet all those play a role in determining health risk. When studies do control for those factors, increased risk of disease disappears or significantly reduced. So once we really pay attention to the whole human, and that includes genetics, that includes mental health, that includes actually their behaviors, their habits, then the importance of BMI and weight really for health really decreases. Speaking of nutrient intake, just out of curiosity, in the audience, how many of you guys have been asked by your doctors what you actually eat? Like, do you actually eat regulated meals? Anyone? Is that a question that comes up a lot? No, okay. So that's my impression too, that, very rarely doctors actually sit down and spend the time to. And it is hard because they don't have a lot of time for those visits anyway, but really ask the person, what does that mean? Or a patient complains that they binge eat, very rarely are they asked, what do you mean? Can you just describe a binge for me so we know literally if we meet criteria for a binge episode or not? So nutrition, a nutrient intake is very, very important, along with say weight cycling. That is something also that needs to be paid attention to. In many cases, if a person loses this, I had this experience firsthand. When the number is different, between your last visit and your visit this year, and the number is lower, nobody says anything. If the number is higher, the doctor rushes in, it's like, oh. So all those things, year after year, visit after visit, those do pile up, and create the board where we are.
Doctor,
Yes,
I have a question from chat. If
yes,
you
hi.
have a second, and when you just asked that question, they said that there is also a lack of training in the dietetics. So usually they take less than a single course.
Absolutely.
And I understand what you're saying as far as like being busy and whatever, but they
You're
are
right
not
on the money
necessarily
there.
trained
This
there.
is actually, this is actually a new thing that doctors now are taking even nutrition course. Like 20 years ago, that was not part of the curriculum whatsoever. So you're exactly right. There's just lack of knowledge out there and, understanding of nutrition. So yeah, thank you for these comments.
And then,
It's very important.
two more if I could real quick. Dr. Ruth in Nigeria said that they are really into integrative medicine. So nutrition is one of the biggest things that they talk about with their clients / patients. But I had a question, and unless I'm getting ahead of myself, but someone asked this earlier and I didn't see it. It said, if you know, what percentage of higher weight women have been victims of trauma? And do doctors even ask about that?
Well, this is a fantastic question. And this is a question that unfortunately does not get asked too much. In our clinical practice, there's a very big correlation between trauma and eating dysregulation, which, would lead to some fluctuations in weight. I don't really know the exact percentage, but there's very strong psychology behind eating as a coping mechanism and then leading to dysregulations in weight. Healthy life in a larger body. Is this possible? Can people have a healthy life in the larger bodies? Yes, 100%. What was deemed, to be the epidemic, BMI between 25 and 30, according to that graph over there on top, those are the people who have lowest incidence of early death. Nearly 1/3 adults in the United States are overweight, so that's 30.7%. This is a lot of people to be very unhealthy and, on the brink of death. So jokingly, however, I'm kind of trying to bring the point that, a healthy life in a lifestyle in a larger body is absolutely possible. Which brings me to the point of set point and health. It is a very important concept about. We hear the question a lot. People come and say, okay, what's a good weight for me? I really do not know. There is no way for me to answer this question just by looking at you. I might have some idea based on your height and your ethnic background, but unless I collect very particular data on eating habits, sleeping habits, some data, on your moods, data on exercise, data on, your parents' health and their weight, data on your health and your weight throughout the years, there's absolutely no way I can tell you what is a good place for you, which is the set point. So human body has mechanisms that help us maintain a healthy weight, or this is the so-called set point. When I assess for this, I ask for a time in your life when, for ladies, you're not pregnant, you're not postpartum, your health was relatively decent, you didn't have any major stressors going on in your life and you felt well. This is sort of the number or the range in adulthood that we feel might be the right place for you. However, if I'm treating a 60-year-old and she tells me, well, when I was 18, I was that weight. Well, none of us is going to be the way that we were at 18 because this is not how our body functions. So that's why the answer, if you know this exact weight, the exact number, the exact BMI, we cannot answer this unless we collect all these data. That's the idea of set point. This is a place where your body functions well. You're mentally healthy, you're physically healthy, you exercise, you eat, you have a life. The set point is usually a weight range, typically between 10 and 20 pounds, and it's not a static number. So if you go to your doctor and they tell you gained 2 pounds, and that's the end of the universe, please do not believe them because this number fluctuates. it goes up and down, and it is a range. At our set points, weight points, our bodies are able to support optimal physical and mental function, so we can actually live a life. That's a very confusing point for many patients, because for many years they're told you have to be certain BMI and certain weight, and they have never been that weight. So we are asking you to get your body to a place that it has never been to, and hope that that might be the right place for it. Another question that I like, I can't change my height, I can't change my eye color, I can change the size of my feet. What makes you think I can change my weight? So this really is true. There are ends of the spectrum that we want to be very careful with, people who are significantly underweight or people who are really very overweight because of something happening in their lives. However, if you are leading a healthy life and you're mentally and physically stable, that number on the scale is really not something. It's a good number to know, because that means that might be your set point. However, if this is higher on the BMI scale, that is nothing to worry about. What can affect the weight and set point? So there's a whole bunch of things. Hormones, genetics, about 70% of individual differences are dictated by genes. So this tells you that, no matter what diet you decide to do, keto, Atkins, you just eat grass and drink water for like months, you will probably lose weight, but your body will continue to push to go back to that same set point. That is your optimal weight. Chronic illness, medication, side effects, yo-yo dieting, all those things can affect the set point, including advice to lose weight when not medically indicated. So finding the set point or the biology of the restrict binge cycle. I'm sure a lot of people in the audience are aware of the fact that if we decide, to lose weight and decide to go on some sort of diet, this is all that you can think of. You decided that I'm not going to, let's say, chocolate, and all that you can think of is chocolate. And that is true for all diets. We restrict the intake, and your whole biology and psychology starts a war on you. It says, no way, I'm going to push this back in the right direction. And for me, for the body to get to the set point, which oftentimes results in actually gaining more weight that you have started with, which is this unfortunate yo-yo effect. So when we restrict, we decide to follow a diet, the body is in a survival mode. It doesn't know why you're starving, right? It doesn't know if it's war, if it's some sort of famine, or if you're sick. The body knows I'm not getting enough nutrition. It cannot detect what you're doing, but what's the purpose of this? So it signals the brain to increase the search for food. This increases our hunger hormones, reduces fullness sensors hormones, the leptin and peptide-1-YY. You can store food in case of further starvation, which is the idea of, regaining the weight more than you started. Your brain will crave carbs, because this is the thing that really gets down to glucose, which is the thing that the brain needs. So when your brain is, how stress works, right? You're under a lot of stress, you're going to get chocolate because this is what the brain needs. Same idea here. You put the body and the brain under a lot of stress, and it's going to go for the carbs. Most diets will tell you to not eat carbs, which is a double whammy, right? You're not eating enough carbs, the body tells you to eat more carbs, and this is like the perfect storm. And the brain will increase the reward value of food. So there are a lot of experiments that are made that, people are restricted from food, and pretty much, this is the only thing that they can think about during that time and long after. The binge restrict cycle. So you restrict, and then, your body says enough is enough, and then it goes into the binge. This cycle really leads to a lot of dysregulations in the body. Weight cycling, increased risk for osteoporosis, increased chronic psychological stress. We all know how this works, increased anxiety about weight, eating disorder behaviors, weight gain, and then stigmatization of people. This is the graph that I have on the left is represents the dieting industry and how much money that business is all about. This is a huge money making machine. So if you are at this point wondering, why are we then told to diet, and why are there so many books and podcasts and diets and meals that you can buy, and that's why, because there's a lot of money locked into this. Unless we find a way to break this dieting cycle, we're going to continue to support this industry and unfortunately result with bad health. The dieting backlash and dieting there in the middle, you can replace this with any type of diet, any type of restrictive intake that is not guided by a nutritionist, by a person who has studied, 6+ years to understand nutrition, is going to result in any of those bubbles. Preoccupation with food being one, decreased willpower, so people feel like I cannot really resist. Satiety, you don't know what this is anymore. People really lose the connection with being between their brains and their stomachs. Body gains more fat when there's the yo-yo cycling. There's low bone density and menstrual irregularities in people who really restrict their intake significantly. So really nothing good comes from following diet that is not prescribed again by a nutritionist. And now this is actually my favorite point of this presentation, that it doesn't matter if losing weight would cure us of all of our problems, because really intentional weight loss does not work. And the data now is very, very strong. In very few cases would a person be able to adopt a diet and sustain it for a very long period of time. This has been, a lot of studies have been done with a lot of different diets. The large scale 2015 study, this is like 278,000 people, show that within 5 years, about up to 98% of people regained all of lost weight and then gained some. So that is pretty much everyone, but 2% are pretty much where they started, plus some, along with all the psychological and biological distress, that they gain because of dieting. The biggest loser contest, I don't have this here, but there was actually a very cool paper on this. So those people are really in very, very large bodies, and they lose a lot of weight. They lost 100+ pounds in a super short period of time. So biggest loser contest, I think by the end of the second year, 24 months, absolutely everyone had regained the weight plus some. And this, you can just imagine what that would do to a body and a brain, like losing 100-something pounds back and forth in a short period of time. So another study here, we have found that 9% of people regain about 2/3 of weight loss within 1 year, and almost all of them within 5 years. So no matter what diet we decide to follow, if we are going way too far from our set point, eventually we're going to get back to it plus some. But still, when you go to the doctor, you're told food is bad for you. Can you recommend a good alternative? Because really, this is what we hear, is that you're told to lose weight, but you still have to get some nutrition.
Doctor?
Yes.
Can I ask a question
Yes.
at this point?
Of course.
We have another doctor that's in the chat, and she is asking, she says, I have a client on the phone. He tells me he weighs 500 pounds and his girlfriend is worried. What do I say?
Okay. So the question that I ask for people who are in larger bodies is, what do you want to achieve? And don't tell me you want to lose weight, because that means nothing, right? Tell me, what do you want to do? I have a patient I treated for quite some time. Her goal was to go to Israel. This is what she told me. She told me, I cannot sit in an airplane chair because my body is too big. So I need to get to a point where I can sit in this chair so I can go to Israel. Took us over 2 years, but she managed to travel to Israel. So we are looking at a functional goal. Just losing weight to lose the weight means absolutely nothing. We want to figure out what would be the goal of this couple? What do they want to do? What is that they cannot do because the person is within this body? And then start it from there. It is a whole different story when you tell a person, our goal here is for you to be, walking to your car and back without any issues, right? That's one goal. And a completely different goal is you need to lose 50 pounds so you can go to your Christmas shopping. Apparently the latter is like very overwhelming. People are like, yeah. When we talk about, however, the 25 steps, that is something that is achievable. So the question is not, I would like for people to start thinking not about weight is the question, not about that number on the scale, but rather what this means from a functional standpoint. A lot of people in larger bodies actually are malnourished. That's something else that I think is a very not popular concept out there. People just they do not eat enough because, the assumption is I'm in this large body. So, I have enough, so I should not be eating. And they're in a constant state of starvation. So one of the very, very, very first interventions that we do is make sure we collect enough data about their eating habits and regulate their eating habits. So really encourage people to eat 3 meals and few snacks a day. So the connection between the brain and the rest of the body gets reconnected. Healthcare providers' views of those in larger bodies, we talked about it a little bit. Lazy, annoying, dishonest, lacking self-discipline, and non-compliant. This is, 2010 study. This is like plain sad because that means that a lot of our providers out there are treating a very large percent of people for whom they think benefit. Patients in larger bodies, as we said, are reluctant to express concerns with their healthcare providers. They don't think that they're taken seriously and they feel disrespected. We discussed some of those in healthcare. Now, circling back to kind of the original topic of this presentation, how do we do that? Going back to that physician's question, I have a person that's 500 pounds, where do I start? So we encourage healthy habits and attitudes. That means collecting enough data on the patient's eating habits and make sure, first of all, that they're eating enough and they're eating enough of decent variety of food that are providing enough nutrition to their bodies. Taking the focus off of weight. So the number, I can tell you in my clinical practice, there's a subset of patients that I weigh more often. People who are in a larger bodies, I weigh them one time when they come to the clinic, just I have baseline data and then really don't for quite some time. Because this is not a piece of information that I follow. This is not a metric that is important at work. What is important is if this person is actually able to do the physical activity that they want to do, if they enjoy dinner with their family, if they're learning the skills about self-care, those are the goals of treatment. Let a person's weight settle where it may, again, same premises. As long as the person is eating well and they are moving their body joyfully, then the weight will get to that set point. Now, this is a slow process, and I need everybody in the audience to understand that sounds great, looks great, takes a very long time. So this is the whole switch in the concept of commitment. Like, I'm not losing 20 pounds for this wedding or for Christmas or for that dinner, with my boyfriend's mother. This is a lifestyle change that I'm choosing to do by nurturing my body, eating regulated meals, eating enough, eating joyfully, also moving my body in a way that, supports my lifestyle. Eventually, 2, 3, some years down the road, it is going to get to the point where it needs to be. Supporting people to feel good about themselves, no matter the outcome. Eating in a flexible manner that we discussed, finding joy in moving one's body and becoming more physically vital. And this means very different things for different people, and that's also important. In respectful care, we need to make sure we hear the patient. And if a person has never ran a marathon, that probably is not a very realistic goal for them to, run marathon 2025. However, if this person really enjoys playing Legos with their kids on the floor and they get hard time, getting on the floor and getting up, that might be a goal to work on. Accepting and respecting the natural diversity of body sizes and shapes, as we discussed. Now, I have a few slides towards the end of this presentation for us as patients. So, the community of people who are going and seeking care, how do we translate this for our healthcare providers? in a way that supports the relationship so we can be supported in our care. Ask questions about conditions and lab abnormalities rather than accept weight being the problem. So when they tell you, or when you hear just lose weight and everything's going to be great, just ask a little bit more questions. Just ask, what in my lab results makes you think that losing weight would be beneficial for me, for example. Have an informed consent discussion about the pros and cons of pursuing weight loss if the provider believes that the data is causational. So if your doctor tells you, you definitely need to lose weight, your blood pressure is going to get better. Then you really need to talk about, what are the pros and what are the cons. People who have history of eating dysregulation, just telling them to lose weight can be very, very harmful. I mean, can be lethal compared to, maybe having hypertension in this particular example. Call out providers for body shaming and easy fixes, like eating less and exercising more. This is honestly easier said than done in the 7 minutes that we have with our primary care doctors. There are some phrases and some kind of sentences that we work through in our group that can be maybe used when you're trying to have an open discussion with your primary care doctor. They can also be helpful with relatives, who tend to shame and guilt related to weight. So there are ways to think of some just literally phrases of what to say to show people that you would not be taking shaming and easy fixes. Report and discuss weight changes or changes in eating behaviors. This is very important, and unfortunately, people are really not asked a lot about that. So we as patients need to be very, very straightforward and open about it. We need to be aware of our own biases and around weight and size and food. Speaking about food can be shameful. It can be very difficult, especially when you're not heard and you feel that you're given the patch of, just lose weight. So I think that this is where our own agency as patients comes through, that, we need to advocate for ourselves and share with doctors what we know and what we think is right. Consider how you speak about weight and food. That's a very important point. I think we're all guilty of saying many things related to weight and food that actually can be harmful for people around us and for us in particular. So being more aware of the way that we phrase things can be helpful. I can tell you the Lindner Center of Hope, we now have those flags. They look like official name flags. I mean, they're for real. That say no body diet talk, and we have them across the center, hoping to promote the culture of people being respectful and really not talking about that, because it is not bringing any benefit to anyone. Telling someone you're on a diet, best thing that it can achieve is make them feel bad that they're not on a diet. Telling someone you're not on a diet achieves the same. So pretty much the blanket statement out there is that, you don't discuss this because this is not beneficial for anyone, the receiver or the provider. And we continue to learn and reflect. In summary, eating and exercise habits are important components of health. Weight in isolation is not. So I don't want to really minimize the fact that weight is important in healthcare. There are many conditions where weight, the fat content of our bodies, the way our hormones work in a larger body, those things are not to be neglected and minimized. However, they should not be taken as a very one-to-one correlation between the big body, larger body, and that particular problem. So in isolation is the important component there, just the number, like this, the physician who said, the patient is 500 pounds, that really means nothing. Because if the person is like 6'7", and they're physically active and they're very fit and their eating habits are good, then really there's nothing to discuss here. Efforts to lose weight are often futile and even harmful, as I discussed, because they put us in this binge purge cycle, binge binge restrict cycle, which results in higher weight at the end. Not everyone is healthy regardless of weight. We need to know more. Exactly that point, that just the number means nothing. Now, I want to cycle back here and tell you that, if I get a call and I'm told that the person is like 62 pounds and they're 5'11" and they're 25-year-old, that's a moment when, we kind of take back and see weight as a metric that really needs to be taken very, very seriously because it's indicative of many issues. So there is this subset of cases, however, they're really very, very, very tiny proportion. In most cases, the number itself really means nothing. Our bodies crave variety, and we crave variety, and we will eventually find their healthy set point with wellness-oriented lifestyle habits. Are wellness-oriented lifestyle habits including the Chick-fil-A? Yes, 100%. Chick-fil-A, the velvet cake, the quinoa salad, the water, occasional wine, yes, all that is wellness-oriented lifestyle. Fighting weight stigma and advocating for body acceptance is everyone's responsibility. I cannot really stress this enough. We all can honestly think of one committed action at the end of this presentation of how we can make this better for ourselves and for people around us. It is not very difficult work once the person truly internalizes why we do it. However, we are totally bombarded by the opposite. So it is very hard to say something that's totally opposite to what everybody else is saying. But this is the only way to be the change. And I'll give you again one last example of my personal life. We have girls' night out and we get together every month, and girls, they talk about, oh, I'm not going to get the French fries because, I ate whatever for lunch. And, this is like every time. It's like, you guys, what I work, my philosophy, just stop it. So, and they don't. So, and I get very, very mad. So at this point, I literally joined this group 15 minutes into the evening because, they get there out of the way and then we can talk about other things. So, but they all know it. I have told them all, because you don't listen and you continue to have those toxic conversations in front of me, I'll just come 15 minutes later. Is this a very good way to change the world? I am not sure, but that group of people, they don't really listen. Important though to catch yourselves when you think those thoughts, to catch your kids when they say things like that. For example, if a 7-year-old tells you that they're not going to eat pork chops because they're bad for you, you really want to be, hold it there, explain to me why a pork chop's bad, for example. Now going back to our first slide, I would like to kind of invite you here to check the biases again. What do we think of this girl? Is she happy? She's not unhappy. No. Okay.
She's thinking about what she's gonna eat.
Or she wants that coffee that the other lady was having in her head. Yeah. Again, bringing back that point time and again, that, just by looking at the person, we really know nothing. This can be a person struggling with severe mental illness, with severe eating disorder. I have seen people who look like that and, are throwing up 4, 5, 6 times a day, for example. So, normal weight, quote unquote, really cannot be used as a metric for health. Questions, before I open for questions, I forgot this slide. There is a very nice book, it's called Anti-Diet, that it's not very, it's maybe 250 pages. It is written by a lady who I think is a nutritionist by trade. And it brings together all those points together that, discusses the dieting industry and how it's a $1 trillion industry. And why we all, one way or another, feel like, we are in this vortex, and what is a way to kind of really step away from it. So that's my spiel. Thank you guys for your attention. I am open for questions. Yes.
Doctor, we have a couple in chat. I'll start with the first one. It says, can you speak to how weight stigma leads to lack of identification of atypical anorexia?
That is a fantastic question, but I assume a professional in the field. Atypical anorexia gets missed in huge percent of the time. So atypical anorexia is a condition where the person struggles with true anorexia, meaning that they are restricting their food intake significantly to the point of really harming their bodies. They spend significant amount of time thinking about their body, their shape, and their weight. However, because they are in a larger body, this does not get recognized. So we usually catch those people, unfortunately, when they are so sick, they're so malnourished that they come to the hospital with severe malnutrition and severe dehydration. Brings me back to the point for the professionals in the field. Please spend 30 seconds assessing eating habits for your patients. If you hear people saying, well, I just eat a meal a day, please go back and ask them why they eat only one meal per day. Because this is the only way for us to collect objective information and to be able to judge and to diagnose a typical anorexia is by collecting this data. Thank you for this question. Very, very important question. Because anorexia in a person in a larger body is equally devastating as anorexia in a person with a much smaller body, which we think when we think anorexia.
I have another question here. They say that there are people out there that really don't know or how to cook. Are you aware of any free, basic, healthy cooking classes in the Cincinnati area?
I love this audience. You guys are like awesome. See, this is something that we actually have discussed in our program for a very long time, that a lot of people lack the basic skills just because they like the basic skills. I don't know how to change a tire. It's a basic skill. I don't know how to do it. People don't know how to cook. There's no judgment there whatsoever. However, they feel judged because when you're told, just make a salad, honestly, there are people who really don't know what this means. I mean, I know this might sound funny for people who really know how to cook, you'll love it, but really cooking is a skill. So our hope is that, with the new developments at the Lindner Center of Hope, we actually will be able to provide a little bit of support around this. Like literally, we do support grocery shopping and that, but, literally just showing people, this is the produce, this is, a cutting board, this is what you do. Free cooking classes in Cincinnati, I don't know if there's anything that's free for real, but what I do with my patients is I use YouTube a lot because they have even very basic skills, like, how to peel a potato or how to cut a cucumber. I can tell you this for a fact because I use them for my children. So some of them are funny. You do it at kind of your own time, so you don't feel judged. So that's one way to approach this. But fantastic question. And I think really whoever asked the question, please don't get discouraged and learn a little bit about cooking because it is a very important skill.
Agreed. There is another question there that says, how do you find a HAES primary care physician in the Cincinnati area? Also,
great question. There is a subset of people, maybe primary care doctors, who would work with this approach. If you go on so the Health at Every Size, they do have a website. And there is a portal there that you can type your zip code and a list of providers. At least this was, I think, last time I checked. There is maybe a place where you can search through this. The other option is Facebook. I know Facebook, not the greatest source, but they do have a Health at Every Size group where people share information about primary care doctors. With this thought in mind, if you happen to wonder if this person would support this philosophy, our advice is to actually have a very honest conversation with them and then maybe even provide them with a consent form around the conversations surrounding weight that you're comfortable with. There are some options online. You can just Google and see, or our nutritionist, one of person from our team, found the informed consent form like this that you can just take to the doctor and say, read through this. And if you agree, we can work together. If you don't, we are not going to work together. People really are starting to catch up with this idea. So my hope is that in the next few years, you'll be able to find more providers like this.
Okay, there's a nice person in the chat that just said there's something called Bear Health, which is a new enterprise with Jeffrey Hunger, who is a weight stigma researcher.
Oh, okay, I'm not aware of this, but thank you, definitely will look into this. Do you want to share anything about that? I mean, the person who said it, if they want to.
Wendy, if you, could you possibly unmute?
Yes. So I was lucky enough to have Jeffrey as a third committee member on one of my students' dissertations. And he discussed this Bear Health. So the problems with the HAES listing in, say, and if you can get it through ASDA, or if you can get it through so Psychology Today, or you can get it through NAFA or wherever, sometimes these things get kind of old. People, the doctors move. Bear Health is a new enterprise, and they're still kind of getting off of the ground, but they're working through these HAES principles and identifying physicians who are willing to adhere to those principles. So, and since Jeffrey is Dr. Hunger is a researcher at Miami U, I have to believe there's some folks in Cincinnati that he's already identified. I could be wrong, but.
This is awesome. So this person created kind of a network of people who are his proponents and their physicians.
Yeah, he's working, and I wish I could remember. I didn't write it down, but he's working with another group, and I can't give them credit because I just don't remember. But he's working with a group, and they together are identifying physicians who follow the HAES principles. So. Again, I don't know too much about it. I just glanced at it the other day, but.
We'll definitely look into that. Miami U is like just around the corner from here. So that can be an awesome collaboration. Thank you.
Yeah, no problem.
So Rhonda, I see that you typed in the chat a question. Would you like me to ask the question, or would you like to unmute and ask this question yourself?
I can ask the question. I have to first of all say how incredibly relieved I was when I saw this presentation. We have struggled to help my daughter. I have 3 daughters, 2 are normal weight, and the third is not. And I feel like she has had physical characteristics since birth. And her doctors told me that once she reaches adolescence, she's going to be in trouble. She used to. And I did all the things I was supposed to as a parent. We didn't put the food on the table. We made our plates on the counter. She didn't drink juice. She didn't have fruit snacks. She never rode in a stroller. She had to walk. Like, it was from birth that, I really felt like she struggled. She used to, when I would throw food away, she would sneak it out of the garbage, constantly hungry, on and on and on. And she was diagnosed as obese at age 5. And as a result of that diagnosis, I've had trouble with insurance paying for any services. I was actually at Children's in Cincinnati, sitting in the waiting room for an appointment when they came out and told me that insurance declined the service. And she was probably 10 at that point. She's now 20, 450 pounds, extremely anxiety ridden over her weight and her appearance and the social challenges and job struggles and everything that goes along with her weight. And so I was just curious if you had any insight, like, how do you approach this as a patient in a way to get insurance to pay for not just a doctor's visit, but a support plan to really help her get her health, her weight, all of those sorts of things under control?
Thank you for this question. This is a very heartbreaking story. Unfortunately, we see examples like that left and right. One way to approach this is through, if there's any comorbid psychiatric component, you mentioned anxiety, for example. If she can be seen by someone who can treat her mental health and support her through this, while really encouraging her to,